Hello, I'm Dr. Robert Kushner. I'm a professor in the departments of medicine and medical education at Northwestern Feinberg School of Medicine in Chicago. Holly, you want to introduce yourself?
I'm Holly Lofton. I'm an obesity medicine specialist, and I practice in the departments of medicine and surgery at NYU Grossman School of Medicine.
And Scott?
Hi, I'm Scott Isaacs. I'm an endocrinologist in Atlanta, Georgia, and I'm adjunct assistant professor of medicine at Emory University School of Medicine.
Well, it's good to get together again to focus this time more on the pharmacologic management. But before we get to that, I thought it'd be helpful to talk a little bit more about the landscape of obesity management and how it is changing. Holly, do you have some thoughts just as an obesity medicine specialist on what you have seen during your career and how that is changing?
Scott and Bob, I'm sure this mirrors your experience. And in my short time, which is 15 years in the field, I've seen it change drastically in many ways. One of which is that not only medical providers, but also patients are really starting to understand that obesity is a chronic disease that needs chronic management. And for example, just because a patient has reached their goal weight, we continue treating them for weight maintenance, developing this concept of weight management rather than weight loss.
Right. And Scott, what are your thoughts?
Well, I think those are some really good points. That when I first started practicing about 25 years ago, obesity was not considered a disease, and we really didn't have a lot of treatments. It wasn't even taught in medical school. So now the approach has changed. It's become much more of a condition that we treat. But I think the biggest thing that we've seen as an improvement are the availability of medications that are safe and effective.
Yeah, I would agree. I trump both of you. I have 40 years of practice, although I agree with both of you. The major change I have seen is one, it's a disease, it's very serious. We're much more aware now of the stigma and bias that individuals with obesity face, much more than we even talked about back then, although it's present. But I think I'm going to sum it up is it's changing from a sense of futility, like I have nothing to offer, why bring it up? It's a willful misconduct, to a point where, Scott, as you're talking, we now have effective treatments where it's really, I think, going from futility to reward when we're treating patients. And I think that's going to even be more exciting as time goes on. We're going to talk about that data today as well. Holly, I'm going to come back to you with a second question. These changes in obesity that we just talked about, what do you expect from primary care professionals when it comes to treating obesity? And what could they do on their own? And when do you think they should refer to a specialty center?
I think we have to look into the surveys that have been given to primary care physicians about why they are not addressing obesity and with their patients who they're seeing for other chronic conditions. And the reasons they pointed to have been lack of time, lack of reimbursement, and finally, frankly, lack of knowledge. So I think we can expect our primary care physicians to also educate themselves, just as they do with other conditions, about obesity as a disease, treat their patients as best they can, where they're using the medication or the lifestyle management. And then when they no longer are able to achieve results or feel that patient's condition is out of their scope, to refer to an appropriate specialist, whether that's an obesity specialist, a bariatric surgeon, or a dietitian.
Mm-hmm. Yeah, and Scott, I'm going to ask you the same question, but you have a unique perspective of being an endocrinologist, and you have years of having primary care professionals refer patients to you for diabetes, right? Like complicated cases. And so with that perspective of having a referral of a chronic disease already, now another chronic disease, obesity, what do you expect a primary care professional to have done before they refer to you?
Well, I think that obesity really is a condition that should be managed within primary care because it's so common and it is the root cause of so many conditions. And what I see a lot of times is that lack of urgency because obesity is a chronic disease. There may not be an acute issue, and so it sometimes gets put on the back burner. So by the time they get referred to me, a lot of times they have diabetes with complications, dyslipidemia, heart disease, and it becomes more management of the chronic conditions. But if we can treat obesity in the beginning, we can hopefully prevent some of these long-term conditions.
Yep, I agree completely. There's a lot more to be done at the primary care level, but I think over time, with more education and advancement of these medications, I think we could expect more from them at the primary care level and the health system level.
So now we're going to talk about the safety and efficacy of the most recently approved and emerging anti-obesity medications. And we're going to start off with a case study. So this is Mr. J, and he presents for a regular checkup at the clinic, and his only complaint is just being more lethargic than usual. He has a long medical history, including obesity, type 2 diabetes, hypertension, dyslipidemia, obstructive sleep apnea, non-alcoholic fatty liver disease, gout, osteoarthritis, and non-obstructive coronary artery disease. So a lot of conditions related to obesity. And you can see his medication list is also equally long. He's taking metformin, empagliflozin, glimepiride, losartan, HCT, amlodipine. He's on a statin and allopurinol. And so when we look at his medical history and his current medications, there's several points that I want to make about this. The first is with diabetes, he's on 3 medications, but his diabetes is still out of control. His glucose is 190 and his A1C is 8.1%. He's on 3 medications for blood pressure, and his blood pressure is still elevated, 150 over 90. And he's on rosuvastatin. His LDL is not at goal. His HDL is low at 38, and his triglycerides are elevated at 360. His weight is 258 pounds, which is a body mass index of 38. His waist circumference is 48 inches. And other factors to point out on the labs, his liver enzymes are elevated, and he has a coronary artery calcification score of 199, which is elevated but not extremely high. So I want to pose this to our faculty. I'll start with you, Holly. How would you approach a treatment for a patient like Mr. J, who has so many ongoing comorbidities that are not well controlled?
The first thing that stands out to me is that the patient's complaint is relatively benign. Fatigue is a very common constitutional finding that can be due to so many factors, whether they're medical or not. It could just be due to poor sleep or more activity. But when we look at his labs, it screams inflammation. We're seeing the effects on his liver, his glucose control is clearly insulin resistant, his blood pressure going up, and this non-obstructive coronary artery disease could very soon become obstructive and lead to a heart attack. So with this patient, I think the first thing I would do is point out that these numbers are not what we're treating. We are treating the longevity of your life. We're treating the likelihood that you're going to have a morbidity due to these abnormalities in glucose and liver enzymes and blood pressure. So just to explain to the patient why it's so important to treat these conditions before we even move on to a treatment plan.
And Bob, all these different conditions, what would you focus on first, and how would you discuss this with him?
Yeah, good question, Scott. I think all of us would recognize that he is at very high risk for a coronary event because of all these risk factors. First of all, these are not optimally managed, but where's the residual risk coming from? And I think what it's coming from is underlying obesity. We talked previously that obesity is associated with 200 or more medical problems. He is working down that list of all of those medical problems. So my conversation with him would be, what else can we do that would impact all of the medical problems that you have that are putting you at risk for having a coronary event? And we would then circle on his underlying weight, and that then would open up the conversation of, is this a good time to talk about your weight? And then have that conversation to broach the topic of obesity and what we could do there that would impact all these medical problems.
I agree. Very good points. This is a classification of over and weight and obesity by BMI. And the point that I want to make from this is that he has class 2 obesity with a body mass index of 38. And so his risk is very high. And he has an elevated waist circumference, but that doesn't change his already high risk based on the BMI itself. And so when we talk about treating to target, the therapeutic weight loss that reduces complications, of course, we want to go for as much weight as possible, but we know that different conditions improve with different variable amounts of weight loss. I think it's really important to point out where Mr. J can benefit from weight loss. And so diabetes prevention, well, he already has diabetes, but you get the maximum prevention at about 10% weight loss. But when you talk about hyperglycemia, more is better. So you're still seeing a decreasing A1C even at 15% weight loss. So there's no upper limit of benefit with when it comes to hyperglycemia treatment. Hypertension, as little as 5%, and you're going to see a benefit in the blood pressure, but up to 15%, even better. Dyslipidemia, 3 to 15% will be in a benefit with triglycerides especially. And then with non-alcoholic fatty liver disease and sleep apnea, he needs about 10% weight loss to see an improvement. So he's got all these different medical conditions which will improve. Some will improve with less weight loss, but they'll all improve when he gets at least 10 to 15% weight loss.
You know, Scott, let me take it from there if I can, and just comment on what you just presented. So you presented a treat to goal scenario, right? Like, what medical problems do you have? How aggressive do we want to treat this patient? And this case that you presented is so illustrative, because if a primary care professional says, you know, if you just changed your diet and moved around a little bit more, you're likely to lose weight, which would be beneficial. And I don't disagree with that, but this is a case where you want to have more aggressive treatment based on this treat to goal slide you just showed. So I'm already thinking, yes, we need to treat obesity, but we need to be aggressive. And when we're talking about aggressive, we are talking about either pharmacotherapy or bariatric surgery. And he's actually a candidate for either one. So I would have that conversation with him very early. And it's very likely he goes, you know, gee, I'm not ready for bariatric surgery, which is fine right now, but we want to introduce the continuum of care early on. And when it comes to pharmacotherapy, there's a lot of things that we think about, but one of which is dual benefits. And the whole idea of dual benefits is, do we have a medication that would treat not only his weight, which is the focus today, but also his diabetes? That's a great example of a dual benefit. And using a incretin hormone, either a dual agent or a single agent, would have an effect on his diabetes. One, you already pointed out his diabetes is not well controlled. So that's what I'm kind of thinking about in him that would hit both of those treatments.
I think those are some excellent points. And he has multiple medical conditions. And so using a medication that helps in different ways is very, very advantageous. And I would just add to that I would even go beyond dual benefits and say multiple benefits, where if we could give him medicine that would help not just the blood sugar and the weight, but also help his liver and his cardiovascular risk, and maybe even his risk for chronic kidney disease, I think that would be even more beneficial. And so that brings us back to the pharmacologic approaches to glycemic treatment from the standards of care in diabetes from the American Diabetes Association. And so when you have a patient with obesity, you have that dual goal of having both glycemic control and weight management. And that's where it's recommended that you choose a diabetes medication that has very high efficacy for weight loss, and that would be semaglutide and tirzepatide. So those are the preferred agents for patients who have diabetes who also need weight loss. So I just want to open up this discussion and ask Holly, do we see this just in type 2 diabetes, or how would you apply this to a bigger population?
We've seen this in diabetes patients, the weight loss benefit, but because of the mechanisms of the GLP-1 and the GLP-GIP dual agonists, we also see weight loss without significant hypoglycemia in patients without diabetes. And that's the beauty of these medications, that they work physiologically. by replicating hormones that were already making in the intestines to give the patient the desired effect of weight loss and or glucose control. So we can talk about some of those trials, both in patients with type 2 diabetes and without.
I think those are all some excellent points. And I want to talk about weight loss in patients with type 2 diabetes and looking at the semaglutide trial and the SUSTAIN trial versus comparators. And I do want to point out that this is showing semaglutide at the 0.5 milligram dose and the 1 milligram dose. And semaglutide is available at higher doses, and you do get more weight loss, and I'll show on some subsequent slides. But I just wanted to start with this in the SUSTAIN trial with diabetes. And you can see that the change from baseline in body weight is listed in the light blue and the dark blue, and you're looking at around 3, 4, or 6%, somewhere in that range with semaglutide, 0.5 milligrams to 1 milligram. And that's compared to much less weight loss with the comparators that are shown on this slide. And the slide is from the SURPASS trials, and this is looking at tirzepatide versus comparators in patients with type 2 diabetes. And we have tirzepatide at 5 milligrams in blue and 10 milligrams in green and 15 milligrams in dark blue. So you can see the increasing weight loss with increasing dose. And this does compare to semaglutide in a head-to-head trial in SURPASS-2, but again, this was the 1 milligram dose of semaglutide. This is looking at 2 different trials looking at weight loss with semaglutide and tirzepatide versus placebo. And I want to point out that these are 2 separate trials. These are not head-to-head trials, but I wanted to put them on the same slide just so we could try to make a little bit of a comparison. And so on the left, we have semaglutide over a 68-week period, and you can see that there's pretty consistent weight loss over that period of time. It starts to slow down a little bit at the end, but you're looking at about 16% weight loss with semaglutide. And then on the right side, SURMOUNT-1, that was the phase 3 trial in patients who did not have diabetes. And we see the 5, 10, and 15 milligram doses. And at the highest doses, you get the most weight loss. And you can see at the 15 milligram dose of tirzepatide, there's about a 22.5% weight loss. And it's also helpful to look at the weight loss categories with semaglutide and tirzepatide. And this is looking at the patients that lost 10%, 15%, etc. with their weight loss. So on the left, again, is semaglutide, and this was from the STEP 1 trial. And this is in patients that did not have diabetes. But we can see that there is a pretty good percentage of at least 5% weight loss in 86% of the patients. But you're getting 10% and 15% weight loss, and 50% of the patients have 15% weight loss. And even with greater than 20% weight loss, it's about 32% of patients. So that's pretty significant weight loss, especially compared to some of the first generation anti-obesity medications, very significant. And comparing that, again, these are not head-to-head trials, these are individual trials, but looking at the weight loss categories for tirzepatide at the 3 different doses, and we can see that the 2 highest weight loss categories are greater than 20% and even greater than 25%. And at that greater than 25% weight loss category, the 15 milligram dose of tirzepatide, there were about 36% of patients who were in that weight loss category. So that's, again, very significant levels of weight loss in these populations. So what I want to do is ask Bob if you wanted to comment on the weight loss categories.
Yeah, thanks, Scott. Things I think about as someone, let's say, who's new to this field and wants to think about, should I be using these medications for the patient sitting in front of me in my office? One thing I want to point out is these trials, identified individuals with obesity or overweight with a medical problem. And it was designed that way specifically so when they went to the FDA for approval, it was generalizable to the patient population likely to use it for. So these are individuals not only with obesity, but also had various degrees of hypertension, dyslipidemia, and dysglycemia, although not diabetes, other than in the SURPASS trial or the STEP 2 trial where they had diabetes. That's one thing. So look at your patient in a clinic. Do they represent the individuals in these trials? Second of all, if you're looking at what you could expect, I like this categorical weight loss better than average because it really gives an understanding. And no one wants to be average, by the way. What patient wants to be average, right? It's like, I'm the one who's going to do really well. How well can I do?
Those are all excellent points.
What I also point out about this, Scott, is I actually like to show my patients these graphs in the office because we ask the patients a few questions. What's your goal? I want to get rid of my medical conditions. I want to lose weight. And when they tell me their weight goals or what their desired condition they want to get rid of, we can then demonstrate you need to lose 5, 10, 15% based on the chart you showed earlier. And then we bring up this, the likelihood of this, say 20% that you'd like to lose occurring with just the lifestyle changes is 3.1% in the SURMOUNT trial or 4.9% in the STEP 1 trial. But you can see how drastically improved that is by adding the medication. And then we can talk about the safety mechanism of it as well, because patients are, of course, concerned about not only efficacy, but safety. So showing these graphs is very telling because our patients have been through the ringer with the lifestyle, and to know that we have safe and efficacious treatment options can be very informative to the patient and give them a lot more hope.
So I want to get back to that point that we were making about the multiple benefits of medication. And just these two graphs that we're looking at here are looking at both glycemic control and lipid levels in patients with type 2 diabetes and the effect of tirzepatide and semaglutide. So on the left, we see glycemic control. And of course, we expect to see the glucose going down. The patients are losing weight, and these medications are indicated to treat diabetes. But here you see the numbers, and there's a pretty significant drop in glucose levels, around 2 to 2.5%. So pretty similar with these groups. And what's interesting to point out is that you're really getting the maximum glucose benefit at the 5 or maybe the 10 milligram dose of tirzepatide. And then on the right, we're looking at lipid levels. And we have all 3 doses of tirzepatide and the 1 milligram dose of semaglutide shown here. And the most dramatic improvements in lipid levels that I want to point out are the VLDL cholesterol and triglycerides. Those are the ones that go down the most with weight loss. And we see less of a change with the total cholesterol and with LDL cholesterol. And there's also a modest increase in HDL cholesterol. But the major impact that we see is really that decrease in triglycerides and VLDL cholesterol. And then everybody is always interested in cardiovascular outcomes. And so I just wanted to highlight these points. And on the left is the SUSTAIN 6 trial, which is looking at cardiovascular risk in patients with type 2 diabetes and semaglutide. And so you can see this improvement in cardiovascular risk over a 2-year period. And so that was statistically significant. On the right is the SURPASS trial. This is just with a primary endpoint of MACE-4, which is cardiovascular death, myocardial infarction, stroke, and unstable angina. And there does seem to be a trend towards an improvement as well. And then finally, I wanted to also point out hepatic outcomes with tirzepatide and semaglutide, especially for patients with non-alcoholic fatty liver disease or NASH. And there was a phase 2 trial with semaglutide for patients with biopsy-confirmed NASH, looking at different doses of semaglutide. But at that highest dose, you see about 59% of patients had some resolution of NASH with no worsening of fibrosis. That's considered a very positive benefit on non-alcoholic fatty liver disease. Of course, we'd love to see reversal of fibrosis, but no worsening is still a very good indicator. with tirzepatide in the Surpass-3 trial, there was MRI assessment of total liver fat content and also showing an incredible reduction in liver fat with all doses of tirzepatide, but in a dose-dependent fashion. And although what we're really interested in is fibrosis, we know that if you get significant reduction in liver fat content, that does translate to a reduction in fibrosis. So again, very encouraging to see these multiple benefits of these medications. And so I just wanted to mention the most common side effects of semaglutide and tirzepatide. They have very similar side effect profiles, but the number one side effect by far is nausea, about 17 to 22%. And then other side effects can include diarrhea, vomiting, dyspepsia or upset stomach, constipation, and abdominal pain. So primarily GI in nature, common side effects.
Are there any contraindications with novel anti-obesity medications? Are there certain patient populations who shouldn't be receiving these medications? Thanks for your time.
Okay, so answer the question about the contraindications of these medications, of the GLP-1 and the GLP-GIP dual agonists, are a personal or family history of medullary thyroid carcinoma or a personal or family history of multiple endocrine neoplasia type 2, which contains medullary thyroid carcinoma as part of that, or obviously serious hypersensitivity to the medication itself or any of the ingredients. And then some limitations of use to know about are that these medications have not been studied in patients with a history of pancreatitis, and they're not indicated for use in patients with type 1 diabetes.
What's the worst call about a side effect that I can expect from a patient when I prescribe a second-generation AOM? I want to be prepared for the worst-case scenario to feel comfortable prescribing these medications.
So what's the worst case scenario? Like, what is the worst side effect that we could expect to see? Well, the warnings and precautions list pancreatitis. Hypoglycemia is not a problem necessarily with these medications by themselves, but if they're combined with insulin or insulin secretagogues, you could see some hypoglycemia. So you want to think about adjusting the dose of the medications that can cause low blood sugar. Also hypersensitivity reactions or acute kidney injury, and that really comes in the setting of severe nausea, vomiting, hypovolemia, and a kidney injury based on that. So I always counsel the patients if you have severe nausea, vomiting. And then another complication to think about is diabetic retinopathy, and this really comes from any patient with proliferative diabetic retinopathy who experiences a dramatic reduction in blood sugar could have an increase in retinopathy complications. And then there's a concern for gallbladder disease, acute gallstones, and that anything that causes weight loss could lead to gallbladder disease.
Sky did, I think, a wonderful job. But it's so interesting that if you look at survey data, at the best, you have 3% of patients with obesity actually receiving an anti-obesity medication. Some of the surveys are even lower than that. And I kind of want to explore that a little bit more. You know, this whole idea of therapeutic inertia, I just wanted to kind of explore a little bit more. And that's what we're kind of talking about, is why our clinicians, even though we'd like them to use it more, they're often not. And I think part of it is knowledge base. They're not schooled or trained in obesity. And I could tell you, at the medical school level, we are starting to introduce more obesity education for the future doctors in America. For those physicians already in practice, you're going to get it through CME and through reading the literature, articles, review papers, and so on. So I would encourage you to do that. In the clinic, though, I think it gets a little, in addition, it gets a little more challenging. Competing priorities. A patient comes in with an earache, a rash. They want to talk about all these other areas, and how do you actually go ahead and talk about obesity? I often talk about a separate obesity or weight management visit as a way of getting around that. That's a lot of ones that they're also doing. lack of comfort in prescribing medication. Holly, I wonder if you could, and you talked about this a little bit more, what do you expect from primary care professionals? But kind of as you talk to your colleagues, you have residents rotating through you all the time. What do you think are the biggest barriers to get them engaged in being proactive and treating patients with obesity and considering to use anti-obesity medications?
And sometimes the idea of a subcutaneous injection, even though it's weekly, can be daunting to the patient and provider. So ease of administration is one of the barriers of some of the providers tell me, because they're used to oral medications, patients prefer oral medications, but actually a weekly injection can be quite beneficial for patient compliance, especially when we get these significant health benefits, as we mentioned earlier.
As an endocrinologist, of course, you're dealing with diabetes quite a bit. And primary care professionals do prescribe insulin, right? Particularly the intermediate acting insulin, right? They seem to have a comfort there, but a little of a discomfort for obesity. But it seems to me an easy kind of transition in thought. And I wonder if you think that these drugs will be picked up by primary care professionals because of that history of using, let's say, intermediate insulin for patients with diabetes.
Well, I think these medicines are perfect for primary care physicians. And really, to be honest, I think they're easier to prescribe and to manage than insulin that has the risk of hypoglycemia, which you don't see with these medications. And the side effects are known and are predictable and are manageable, and we can counsel our patients on how to minimize the side effects. And so, yes, it's an injection, but I think that the patients, they seem to accept these injections. They don't seem to have that fear of an injection like you see with insulin. And they also don't seem to feel like it's a failure. A lot of times when we put patients with diabetes on insulin, they feel like somehow they failed in their personal management of their own health. And I just don't see that as much with this class of medications.
Yeah. And of course, I'll also add, which I didn't when I posed the question to you, is they're already using GLP-1 receptor agonists for diabetes, right? Either daily or weekly injections. So this is the same, we're often the same medication, different dose, different pen system, but applying it, of course, for a different disease. And then lastly, misconceptions. So we deal with the misconceptions of it, how they work, and go ahead and how to use them. So those are my thoughts about therapeutic inertia that we really need to break through in education and in comfort when using these medications. The other thing that, and we've talked about this before, but I want to go back to it, when choosing a medication, you have drug factors. We talked about dual benefits. And then the last, of course, is patient factors that you need to think about. And that has to do with, is a patient interested or not interested in an injection medication versus an oral medication? Preference of how they want to use it. And the other is access. That I think is a huge area that we need more improvement on. Access regarding mostly insurance coverage. Generally, these medications are not covered by governmental insurance. Medicare not covered, Medicaid, depending upon the state. And then, of course, insurance coverage as well. And Holly, I'm going to ask you, how do you have that conversation with patients when it comes to access and or affordability?
I think of access in two ways. One, there's what the patient is willing to do. Are they willing to do a medication? That's an injection, and that is usually no problem with many of my patients. And then we start the process of the prior authorization that usually exists to get these medications covered. It's not the barrier of the physician. It's not the barrier that there's anything wrong with the patient, but the insurances want to be sure that we're using the medication appropriately, that the prescriber understands the medication, and that they're dispensing or giving accessibility to the right patient. So that's the reason why these access issues occur. What can be frustrating to the patient and provider is access can change. Sometimes patients have lost weight well with the medication, and the next time we go for authorization, they say, well, the patient now is too low in weight to get the medication anymore. So those factors on a more global level, a more policy level, still continue to need to be addressed so that we can continue long-term chronic treatment for these weight management patients. And I do have the patient reach out to their human resources department, and even sometimes those government or congressional level leaders who make these decisions about what the patients have access to.
Very frustrating for patients and providers combined.
I think those are all some really excellent points. Just to emphasize the point about doing a prior authorization, because what I've seen is that most patients don't know if they have coverage for anti-obesity medications. And if they call their insurance company and ask, they usually can't even get the answer. And so the easiest thing is just to submit the prior authorization, and then you can know, because it's so frustrating if you prescribe a medicine to a patient, you give them a sample, they go home, they try to get it filled, and they can't get it filled, and you feel like that whole appointment was wasted, spending all that time counseling them on the medication they can never take. So knowing what's available right in the beginning, I think, can be very helpful. So getting back to our case study with Mr. J, after careful consideration, we decided to talk to Mr. J about adding tirzepatide to his current medication regime. And you might ask, would he be open to discussing a therapeutic option that could help with some of his other medical issues?
Doctor, I'm concerned. I'm concerned about this injection because I've already taken 7 different medications that you know about, and I'm concerned. Is this like insulin? Is it worth it? You think it's worth it? I'm just afraid to keep putting more medicines into my body.
So, Holly, how would you address Mr. J's concerns?
I first recognize that his concerns are valid and that his medical conditions are not at goal, as we discussed earlier in the case, and that it can be frustrating to continue to add medications yet not reach the best capacity of treating these medications so that the risk is minimized. And they may be a little hesitant to add another medication at this time when they're presenting for fatigue. Say, I'm just tired, doc. Why are you giving me something now to inject it? And the way that we can spin this to the patient and say, this will improve the following 5 conditions and hopefully be able to get you off some of your other medications, improve your quality of life, and decrease your cardiac risk, explaining it in a way where we're adding now to take away later with an improved outcome is really important for our patients with diabetes and these other chronic conditions. And what I would do in this situation is ask him to, let's take a look at your medication list, and we circle the meds that are for your glucose, let's circle the meds that are for your heart, let's circle the meds that are for your hypertension. And when we think about bringing in something like tirzepatide, it really fits all of those circles and can help the patient decrease the number of medications that he needs to take frequently, however, improving the likelihood of his longevity of his life and improving the state of these conditions that he's worried about. So while we can't say for sure that this will ultimately decrease his medications, based on the evidence, we would think that he would need fewer medications and have better outcomes. And I do think it's important to tell the patient the difference between a GLP-1 or a GLP-GIP dual agonist and insulin. Because another thing I would point out about his medication list is he has some medications which can cause weight gain. And these are not ideal given his current body weight and the state of his condition. So by tackling his glucose control, his hypertension, his triglycerides, as well as his weight, we can help the patient have overall health. But we want to make sure that the patient really understands that we may add on initially with the goal of decreasing medications in the future.
Oh, okay. I will take it if my insurance covers it. But do I have to take it my whole life? What happens if I stop taking it?
Holly, how would you answer that?
Well, one thing we have to remind Mr. J here is that we consider these medications to be for chronic weight management and also for Mr. J for diabetes management. They change the physiology while the patient is taking them for about 7 days, but it does not change the physiology forever. So explain that aspect of the chronicity of these conditions and the high likelihood that these medications may be lifelong is important to have the patient understand why it may be chronic and to help them comply. But I also use the amount of time when they're losing the most weight, that first 6 to 8 months, to explain that this is a condition. While the patient has that appetite control, while they're getting weight loss consistently, while they say they're feeling normal, say this is because not only are you doing your piece from the lifestyle perspective, but we have this hormonal control of the medication to help you feel this way. But it will not continue forever if we don't continue both the lifestyle and the medication that was decided at the time.
Oh, okay. That makes sense. What about the side effects? I read something on Facebook about these medicines that I didn't like.
Yeah, so we talked a little bit earlier about side effects, but let's revisit that because that is so important for us as the prescribers to make sure the patients have realistic expectations about side effects, so they know what could potentially develop, and most importantly, how to mitigate those side effects. So to reiterate what Scott's already talked about, there's a commonality in the side effects with semaglutide and tirzepatide, since they're both really incretin hormone mimics or replicate insulin incretin hormones. And those are nausea in large part from reduced gastric emptying, plus potentially direct effect from the brain. Diarrhea, vomiting, constipation we talked about. Heartburn is something else that I see among our patients. Hypoglycemia is really seen in someone who's already on an insulin secretagogue, like a sulfonylurea or insulin, which can increase the likelihood of hypoglycemia. And some of these other ones we're already seeing as well. And we have pretty good data from both tirzepatide trials and semaglutide trials to back this up. And there's a very nice slide that comes from the SURPASS trials, which are the diabetes trials. And what it looks at is the percent of individuals developing nausea across the 3 different doses of tirzepatide compared to the lower dose of semaglutide 1 milligram. And it's color-coded according to the severity of nausea. And it's 2 things jump out at me. One is the nausea primarily occurs early during the dose escalation phase when you're initiating the drug and you're escalating it every month after 4 doses of each of the particular dose. And then it subsides as time goes on once you've reached the maximum dose. The second thing that jumps out of this nice slide is that most of the nausea is described by the patient or the subject in the trial as mild. Moderate is much less, and rarely is it severe. So by talking to patients about when you initiate the drug and you're going through the dose escalation phase, that's when you're most likely to experience nausea. Vomiting can occur as well, but it's really much, much less frequently seen. When we look at semaglutide at the 2.4 dose, this is the dose that's approved for weight management. Again, we see the same common side effects. Nausea is the most common, followed by diarrhea and vomiting, and constipation is also seen. And the frequency compared to placebo occurs mostly during that dose escalation phase during the first few months, with nausea reaches about 20%, diarrhea much less, vomiting much less as well. So again, getting the patient to be aware of this through realistic expectations really reduces the phone calls and the messages you're going to get through the electronic medical record. How to mitigate these effects is very, very important, and this has to be given up front. You want to stay ahead of the curve to prevent it from happening. You can mitigate these side effects by being proactive up front, such as eating slowly. When you start feeling full, stop. So you're paying attention to portion control. Don't skip meals. Don't go long periods of time without eating. Reduce the amount of fat in the food, because fat independently reduces gastric emptying, so you don't want to add it to that. And getting into a healthy eating pattern, again, is very, very important. Other lifestyle things that can help is get fresh air, good sleep and so forth. But those dietary recommendations are very, very important. Holly, do you have any special tips that you have on top of that you talk to your patients about?
Alcohol also slows down the stomach emptying process, and you combine that with a GLP-1 or GIP agonist, and then you have this just churning, where you have slow gastric emptying, you have a fat, say if there's a wine and cheese party, and you add the alcohol, and everything just sits there and churns. And this has been a situation some of my patients have reported vomiting when they were well past the nausea phase. So those types of foods in combination, especially the later on it goes in the evening, can really generate those side effects which are untoward. So when we're looking specifically at semaglutide or tirzepatide, these are in the current forms single cartridge medication. So you use one cartridge and you throw it away. It is important to refrigerate the medication for it to be optimal for use. I tell the patient it should be refrigerated, not be frozen. And at the time the patient decides to take the medication, they can remove one cartridge from the box, leave the rest refrigerated, and then pick an area of the body they'd like to administer the medication. For these drugs, you can use the upper arms, and I do like to point to these areas so the patient is on the same page, the upper arms, the abdomen, or the front of the thighs. And depending on the medication specifics, there's usually a cap to be removed and some twisting to be done, and the medication can be injected. Of course, depending on which medication you're doing, there may be one or two clicks. And I often refer the patients to a video for their specific medication in case they get home and have other questions. So making sure that they know what to look for, to refrigerate the medication, and also to know if the medication pen might have misfired. This happens infrequently, but sometimes a patient has told me they dropped the pen and then it no longer worked, or they noticed when they did the injection, a lot of liquid leaked out. So in the event of a misfiring or the patient incorrectly injects, that is something that we can also address in the clinic. Furthermore, I can't express enough how important it is to have a patient come back in, or on a video visit if you do those, to explain to you how they administer the medication in the event that they are having no effect. If the patient says, I lost no weight with this in 2 months, I didn't feel a thing, and you gave them a pretty hefty dose where you expect some either side effect or some appetite change, I always bring those patients back and ask them to show me with the demonstration pens how they administer the medication, because if they're not administering correctly, of course, the medication will not work.
Those are great tips. The one I want to highlight that we talk about in our clinic as well, which I think will also make it easier for the primary care professional, is to make sure the patient watches an injection video. I think that really takes care of a lot of the angst that they have, either on the website from the manufacturer or on YouTube. You can just go injection video. And at least I find most of my patients, once they watch it, they go, okay, it's less complex than I thought. So in addition to all the tips that you do as a provider, the injection video is so helpful. Both of these drugs are dose escalated, which is, of course, what we do as providers. We talked before about side effects, and I was mentioning mitigating factors that reduces side effects. This is probably one, in addition to changing your diet, which we talked about as well, that the patient needs to do proactively. The other thing we do as providers, according to the package insert, is to slowly dose escalate. I think we as prescribers are familiar with doing that with many other medications. You start low and you build up, and so on. Antidepressants, sometimes we do that. In this case, it is extremely important, because if you start at the highest dose, you're going to have side effects, almost assuredly. So both semaglutide and tirzepatide, we start, according to the package insert, the lowest dose. We escalate every month, and we do that in clinical practice as well. With semaglutide, we start at 0.25, and over multiple months, we get up to 2.4 if we choose to go that high. For tirzepatide, we start at 2.5 milligrams and dose escalate up to 15 milligrams if we want to go that high. Key caveats here. You don't have to dose escalate every month. If they're having a side effect, slow the escalation down. It's not a race. They could stay at the same dose until they're comfortable. That's number one. Number two, you can decrease the dose if they're not tolerating it, depending on which drug you're using. And number three, always look at the response of the patient. When I'm using this drug, all my patients get back to me through electronic medical record and tell me what is their weight, are they having any side effects, and are they having the intended effects, which is reduction in appetite. And that's really what I do when I decide whether to change the dose or not. And as we said before, sometimes there are super responders, in which case there's no reason to go any higher. They'll say, I'm not hungry. I don't even get a signal to eat. You clearly don't want to go any higher versus someone who is doing well, no side effects, and you may want to move that dose up a little bit higher. So if we go back to the case of Mr. J, after confirmation of Mr. J's insurance covered tirzepatide, he began dose escalation. 6 weeks after initiation, Mr. J leaves you the following voicemail.
Hi, doctor. I'm sorry to bother you. I want to see if you can help me with some nausea that I've been having when I started on the higher dose. It's not really bad, but I don't want it to get worse. Thank you so much for your help, and you have a nice day. Thank you. Bye.
So we already talked about changing the diet, so we would always go over that again. Are you watching your portion sizes, stopping when you feel full, reducing the fat in your diet, not skipping meals, having a balanced diet? With that, however, some people continue to have the side effects. They're almost all gastrointestinal, like nausea, diarrhea, constipation, sometimes vomiting. But in my case, it's uncommon that I have to actually prescribe an anti-nausea medication or an anti-diarrhea medication. I do have to talk about constipation, stool softeners, fiber, fruits, vegetables, and so forth. I will prescribe it if I need to, but I kind of don't want to prescribe a medication to deal with the side effect of another medication, but sometimes I do. Most of it is dealt with lifestyle alone. Scott, what has been your experience?
Well, I would just have to say that everything you just said is exactly the way I do it. And I don't like to prescribe a medicine to treat the side effect of another medicine either, but we do it. And the time that I seem to do it the most is when it's a patient requests the medication before they've even started. They just have that fear of nausea and they want it. And a lot of times they never actually end up needing to take it. And so just going back to this discussion and everything we've talked about how to counsel the patients, how to eat, what to expect, and to just give that reassurance that most of these side effects go away after a few weeks. That enough is usually can get the patients past those initial side effects where they can tolerate the medication and continue to lose weight.
Holly, what are your thoughts?
I really think it's important to let the patients know that having the side effect, again, shows you that the medication is actually slowing down your stomach emptying. You don't just feel more full, your stomach is actually emptying more slowly. So think carefully about what you're putting in, how fast you're putting food in. And this is also a metric that tells me we don't need to increase your dose necessarily next time.
I do want to just maybe end this short conversation with a few key points, and that is for the primary care professional, this is a medication you need to manage the patient carefully. Make sure you're responding to the electronic medical record messages, anticipate likelihood of side effects, and make sure you do those counseling tips early on. And you can get the vast majority of patients through these early stages where they think they're not going to do well. Most of them actually do well, but you do need to manage them through that period of the dose escalation.
Okay, so continuing with our case study with Mr. J, just want to go over the results of after he started tirzepatide. And we have here our results at 6 months and at 12 months. And we can see that with his weight, he lost about 28 pounds at the 6-month period. And by 12 months, he had lost an additional 34 pounds. So his total body weight was 196 pounds. And he brought his BMI down from starting BMI of 38 down to 29. So he went from class 2 obesity to the overweight range. And that's overall a 24% weight loss, which was stable at 12 months. So right in line with what we saw with the tirzepatide studies. And he was also able to stop 2 of his medications, his glimepiride and his hydrochlorothiazide. And then we also saw some other improvements in metabolic parameters. His glucose improved, his blood pressure improved, his lipids improved, as well as his liver enzymes, and his FIB-4 score went down into the normal range, into that low risk range. So really that multi-system benefit from weight loss with all of these different improvements. I want to ask Bob and Holly their comments about what they think about Mr. J.
And this is almost kind of an ideal patient for a drug like tirzepatide. And his outcome of about 24% weight loss is excellent. And I think it symbolizes or illustrates so well, Scott, the multiple organ effect of weight loss and using an incretin drug like tirzepatide. And this is something I would be having a conversation with Mr. J about continuing on this medication long term, because that's how it works.
Yes.
I think all of us and the audience too are wowed by all these numbers that have improved A1C, triglycerides. But we have to think about how Mr. J feels. I'd be curious to know, how's his fatigue? He clearly has less inflammation with the A1C dropping, the fat percentage loss. And what the patient really notices, obviously the weight loss, but this decrease in waist circumference, which to us is imperative to make us think that there's a lower cardiac risk. We put all these numbers into a cardiac risk assessment tool, and he has a significantly less risk of an MI, a stroke. So the patient's feeling weight loss, I'm sure he's getting compliments, he's on fewer medications, he's buying different pant sizes and belts. We know that overall his inflammation has decreased, and hopefully his fatigue is improved.
How do I handle a situation where the patient wants medication for weight loss but hasn't tried to make any changes in lifestyle?
Here's a question which is really very important. If I see a patient who comes in who has never tried to change, doesn't have much knowledge about it, let's say the nutrition literacy, skipping meals all day, I am personally hesitant to start a medication on day one. So sometimes in that patient, I may sequence dietary counseling prior to medication, but if they haven't been successful in the past, I will then go ahead and use the medication and guide them at the same time. Holly, how do you handle that?
Well, I think it's important the patient understands the combination therapy is the most effective, and that actually medication without lifestyle management works less than lifestyle alone in many times. So we can't rely solely on the physiologic changes. And I tell the patient, we're going to partner to optimize your plan. Some months you may do more exercise, some months you may do less, because these environmental changes warrant a change in plan. And whether that's give you more exercise or changing your medication dose to suit your environment, I just want to make sure the patient knows I'm there as a partner, and we need to work together to get the best long-term program for them.
Hi. How can I be sure to be reimbursed for an obesity visit, and how do I know what the correct coding is to bill for? Any help would be appreciated. Thanks.
How can I be reimbursed for the time that I spend discussing the obesity treatment plan with my patients? And we know that our patients have so many complaints regarding their acute medical conditions, and the obesity often needs its own medical visit to discuss this chronic condition. So what I recommend is first bringing the patient back after they've agreed to talk about their weight condition and determining what their weight condition is. So this patient, are they having obesity? Is it a different class? And also if there's anything that's contributing to the obesity, such as a medication, that can be a billable code. Now, if patients have weight-related comorbidities such as hypertension, coronary artery disease, sleep apnea, you can combine that obesity code or BMI code with that condition, because you are really treating both in that visit, and just make sure to document both for the weight recommendations as well as anything related to, say, their sleep apnea or hypertension. Furthermore, as patients start to lose weight and come back and see you more frequently, there may be periods in which they gain weight, or at the initial visit, their complaint is really weight gain. They've gained weight over time. So billing for the code of weight gain can be reimbursed, because that is considered a reimbursable condition. Also, if you see patients who have had bariatric surgery in the past, billing for post-bariatric surgery weight regain is definitely something that's reimbursable. The tricky part occurs when the patient has reached goal weight and you have them on a medication, you have them on a plan that works, and their BMI is, say, 23. What can I bill for in this patient? They have no medical conditions anymore, but they're still continuing to see me for maintenance. And I actually bill for healthcare maintenance, and you can throw in some other preventive tools in there. Remember, they should have their colonoscopy if they're due, their mammography if they're due, and continue to address their weight because healthcare maintenance is something that can be reimbursed as well.